Hello there. So now we'll be starting with respiratory medicine as we finished rheumatology earlier. So yes, let's go scenario wise, and we'll also be referring to the charts along with the questions. Okay, so first scenario, we have a 33-year-old man having mild headache, myalgia for last 2 days, followed by high fever, chills, rigors, and a cough. His cough was initially dry but progressed to be productive, and he has just returned from a conference in Greece where he mentions that he swam and used the hot tubs in the hotel. He has a temperature of 38.1 degrees Celsius, is seen to be dyspneic, chest x-ray shows patchy alveolar infiltrates. What is the single most likely organism which would have caused his symptoms? Okay, so here Legionella pneumophila is a causative organism that causes Legionnaire's disease, which is a severe potential fatal acute pneumonia acquired by droplet inhalation of water which is contaminated. Okay, again, Legionella pneumophila is the causative organism which causes Legionnaire's disease, which is a severe potentially fatal acute pneumonia acquired by droplet inhalation of contaminated water. Legionella pneumophila is found in natural water supplies and soil. It is also found in many recirculation and water supply systems. For the purpose of this exam, we have to look out for hints like traveling, hotel stays, whirlpool spas, hot tubs, as often they would put one of these hints in the question. So if the examiners would like you to select Legionella pneumophila as the answer, we have to be careful about these hints. And let's see if we have a chart on this. So that was Legionnaire's disease or Legionella pneumophila. I mean, the causative organism is Legionella pneumophila, which is causing Legionnaire's disease, and this is a type of severe, fatal, and acute pneumonia which is acquired by droplet inhalation of contaminated water. It is found in natural water supplies, soil, so it can be found in recirculation and water supply systems as well. So we have to be careful about the main points or hints given in the question, like traveling, staying in the hotel, water pools, whirlpool spas, and hot tubs, etc. They would point towards Legionella pneumophila, which is causing Legionnaire's disease, fatal acute pneumonia caused by droplet inhalation of contaminated water. Okay, so now let's move ahead with this, and let's see if we have any other fact. So treatment for Legionella is with clarithromycin, rifampicin, or fluoroquinolone. Yes, treatment is with clarithromycin, rifampicin, and fluoroquinolone. And apart from this, it is an aerobic gram-negative bacilli, and it is causing two forms of disease: pneumonic versus non-pneumonic. Non-pneumonic is called as Pontiac disease, which is flu-like, and pneumonic called as Legionnaire's disease, which we already studied. And treatment is with quinolones, macrolides, tetracycline. So macrolides, quinolones, tetracyclines, clarithromycin, rifampicin, fluoroquinolone. So yes, macrolides are first line, fluoroquinolones are second line. In Legionnaire's disease, macrolides are first line, fluoroquinolones are second line. That is the important part in the treatment. And antibiotic of choice is erythromycin, and we already studied clarithromycin, rifampicin, and fluocinolone. And we can see blackcurrant jelly sputum in case of Klebsiella. Okay, that is unrelated. Okay, history of swimming and hot tubs are clinchers for Legionella pneumophila. So yes, there is a history of travel there. Okay, so now let's move ahead. Next, a 33-year-old chronic smoker attending the outpatient department with complaints of persistent cough, copious amount of purulent sputum, and dyspnea. He has a history of recurrent chest infections in the past. Coarse crackles are found at the base of his lung on auscultation. Bronchiectasis is suspected. What is the single most definitive test to diagnose bronchiectasis? They are asking single most definitive test. So the gold standard for diagnosis of bronchiectasis is HRCT of the chest, that is high resolution computerized tomography. High resolution computed tomography, HRCT, which has got very high sensitivity and specificity for the diagnosis, and it has now replaced bronchography. In adults, bronchoscopies and bronchoscopic samplings of the lower respiratory tract do not have a place in the routine investigation of patients with bronchiectasis. Bronchoscopy is used for patients in whom serial testing of sputum does not yield any microbiological information and who are not responding well to the treatment, or if HRCT suggests atypical mycobacterial infection and sputum culture is negative. This is important, in which cases bronchoscopy is useful. So, along with the fact that gold standard for the diagnosis of bronchiectasis is HRCT of chest, HRCT has got very high sensitivity and specificity for the diagnosis, and it has replaced bronchography. HRCT is high resolution computed tomography. In adults, bronchoscopies and bronchoscopic samplings of the lower respiratory tract, they do not have a place in the routine investigations of patients with bronchiectasis. And this bronchoscopy is used in patients in whom serial testing of sputum is not yielding any microbiological information. So we are doing continuous testing of sputum, but there is no yielding of microbiological information, and those patients are not responding to the treatment as well, and they are not responding to the treatment. There is no yield of microbiological information from the sputum samples, and HRCT is suggesting atypical mycobacterial infection, and sputum culture is negative. Sputum culture is also negative. So yes, initial diagnosis can be chest x-ray, but definitive diagnosis is HRCT. Let's study a little more about bronchiectasis. Now, bronchiectasis is a irreversible abnormal dilatation of small and medium-sized bronchi with chronic airway inflammation, and it is associated with chronic sputum production, chronic cough, recurrent acute chest infections, and airflow obstruction. So again, bronchiectasis is an irreversible abnormal dilatation of small and medium-sized bronchi with chronic airway inflammation. It is associated with chronic sputum production, chronic cough, and recurrent acute chest infections and airflow obstruction. So these are the things which are associated, like chronic sputum production, chronic cough, recurrent acute chest infections, and airflow obstruction. Now, talking about etiology, the disease is caused by chronic inflammation of the airways, any condition which facilitates infections and inflammation. It can cause damage to the lung. Bronchial damage results in impaired ciliary function, leading to accumulation of secretions and secondary bacterial infections of the collected secretions, which inflammatory response further damages the lung. It goes in a vicious cycle. So the disease is caused by chronic inflammation of the airways, and any condition which facilitates infections and inflammation, it can cause damage to the lung. Bronchial damage results in impaired ciliary function, leading to accumulation of secretions and secondary bacterial infections of the collected secretions. And with further inflammatory response, it causes damage to the lung and it goes in a vicious cycle. Now, post infection, childhood respiratory okay, so post-infection, childhood respiratory viral infections, it can be of different types or there can be different causes for bronchiectasis. First is post-infection, that is childhood respiratory viral infections like measles, pertussis, respiratory syncytial virus, tuberculosis, bacterial pneumonia, etc. Infection is the most common cause of bronchiectasis. Second, immunodeficiency, HIV infection, selective immunoglobulin deficiencies. So, immunodeficiency states may result in persistent or recurrent infections. Now, third, connective tissue diseases. They include rheumatoid arthritis, Sjogren's syndrome, systemic sclerosis, systemic lupus erythematosus, Ehlers-Danlos syndrome, Marfan syndrome. These are the connective tissue diseases. Now, toxic insults can be like gastric aspiration, inhalation of toxic gases, then congenital defects. The most important is cystic fibrosis. Bronchial obstruction and bronchopneumonia are more likely to cause a focal bronchiectasis, whereas the other causes are more likely to result in a diffuse kind of a disease. Now, the most important cause to exclude is cystic fibrosis. Even relatively mild bronchiectasis diagnosed in middle age can be due to cystic fibrosis. In the examination, we have to look out for a history of recurrent pneumonias in the question. Clinical features: first, persistent cough with purulent copious sputum production. The keywords in the exam are copious amounts of purulent sputum or cup full of sputum. Second, non-specific respiratory symptoms like dyspnea, chest pain, and hemoptysis. Third, coarse crackles, which are the most common finding, and these are heard in early inspiration and often in the lower zones. And so these are coarse crackles, which are the most common finding in early inspiration and often in the lower zones. Okay, so next, large airway rhonchi. Rhonchi are low-pitched snore-like sounds, and V's may also be present. So these are the clinical features. Now, diagnosis is made clinically with the high resolution computerized tomography, which is HRCT, chest for confirmation. A baseline chest x-ray should be done in all the patients. Early chest x-ray findings may be normal in patients with bronchiectasis. Chest x-ray in advanced cases may show 1 to 2 centimeters of cyst, peribronchial thickening, crowding of the bronchi, tramlines or ring opacities. The main value of a chest x-ray is to exclude other causes of symptoms. HRCT findings include bronchial dilatation, lack of normal tapering of bronchi peripherally, and bronchial wall thickening. We have to pay special attention to the findings of the chest x-rays and HRCT as they are commonly seen in the exam. Now coming to the treatment, a damaged lung cannot be repaired, so the basis of management is to prevent or at least slow down further deterioration. So it includes bronchodilators, chest physical therapy, postural drainage, which are used to control and improve drainage of bronchial secretions, stop smoking if the patient is a smoker, and immunization against influenza and pneumococcus. Then long-term oral antibiotics for patients having 3 or more exacerbations per year requiring antibiotic therapy, or patients with fewer exacerbations which are causing significant morbidity. So this is about bronchiectasis, and let's just go through it once again. First of all, bronchiectasis is the irreversible abnormal dilatation of small and medium sized bronchi with chronic airway inflammation. So there is both abnormal irreversible dilatation of bronchi and airway inflammation, chronic airway inflammation. These two things happen at the same time. It is associated with chronic sputum production, chronic cough, recurrent acute chest infections, and obstruction, airway obstruction. So these are the things which would be there. Chronic sputum production, chronic cough, airway obstruction, and recurrent acute chest infections. Now the disease is caused by chronic inflammation of the airways. Any condition which is facilitating infections and inflammation in the respiratory system, it can cause damage to the lung. The bronchial damage results in impaired ciliary function, which is leading to accumulation of secretions and further secondary bacterial infections of these collected secretions, which with associated inflammatory response causing further damage to the lung. So it is kind of a vicious circle here. Like, because this disease is causing chronic inflammation of the airways, and any condition which causes or facilitates infection and inflammation, it can cause damage to the lung. So bronchial damage, it causes impaired ciliary function, because of which it leads to accumulation of secretions. There is no proper drainage, accumulation of secretion, and secondary bacterial infection of these collected secretions. So along with that, there is inflammatory response which causes further damage to the lung. So the body sets into a vicious circle here. And coming to etiology, the causes, now first is post infection. Childhood respiratory viral infections like measles, pertussis, respiratory syncytial virus, tuberculosis, bacterial pneumonia, they can be a cause for bronchiectasis later in the life. So post-infection is the most common cause of bronchiectasis. Infection is the most common cause of bronchiectasis. Infections like childhood respiratory viral infections like measles, pertussis, respiratory syncytial virus, and then tuberculosis and bacterial pneumonia, etc. Second is immunodeficiency. HIV infection, immunoglobulin deficiencies, immunodeficiency states. They may also result in persistent or recurrent infections. Third is connective tissue diseases. Connective tissue diseases like rheumatoid arthritis, Sjogren's syndrome, Marfan syndrome, Ehlers-Danlos syndrome, then systemic lupus erythematosus, systemic sclerosis. So these connective tissue diseases are also another cause of bronchiectasis. like rheumatoid arthritis, Sjogren's syndrome, systemic sclerosis, Ehlers-Danlos syndrome, Sjogren's syndrome, Marfan syndrome, SLE or systemic lupus erythematosus, etc. Fourth cause is toxic insult. Toxic insult like gastric aspiration or inhalation of toxic gases. Both of them can also cause bronchiectasis. Toxic insult will include inhalation of toxic gases or gastric aspiration, aspiration of gastric contents. And then fifth one is congenital defects. Congenital defects, the most important is cystic fibrosis. So post-infection, immunodeficiency, connective tissue diseases, toxic insults, and congenital defects like cystic fibrosis. Now, bronchial obstruction and bronchopneumonia, they will likely cause a focal bronchiectasis, whereas these other causes which we studied, they usually cause diffuse kind of bronchiectasis. The most important cause to exclude out is cystic fibrosis. Even relatively mild bronchiectasis diagnosed in middle age can be due to cystic fibrosis. So in the examination, we have to look for the history of recurrent pneumonias in the question. Now coming to clinical features. First is persistent cough with copious amount of purulent sputum. Persistent cough with copious amount of purulent sputum production. These are the keywords: copious amount of purulent sputum or cupful of sputum. Then non-specific respiratory symptoms like dyspnea, chest pain, hemoptysis, they may be there. Third, coarse crackles, which are the most common finding. We can find coarse crackles in bronchiectasis, and these coarse crackles would be heard in early inspiration and often in the lower zones, during early inspiration and in the lower zones, coarse crackles. Fourth, we will also find large airway rhonchi, which is a low-pitched snore-like sound. Large airway rhonchi. Rhonchi is a low-pitched sound. Low-pitched snore-like sound. And last feature is wheeze. So coarse crackles, large airway rhonchi, and wheeze. So persistent cough with copious amount of purulent sputum production or cupful of sputum, non-specific respiratory symptoms like chest pain, hemoptysis, and dyspnea. Then coarse crackles, most common finding found in lower zones and in early inspiration. Then wheeze may also be present. Large airway rhonchi may also be present, which is a low pitch sound. Now diagnosis. Diagnosis is made clinically. Initial diagnosis can be a chest X-ray. Definitive diagnosis is HRCT. So diagnosis made clinically with high resolution computed tomography for confirmation. A baseline chest X-ray should be done in all the patients. Early chest X-ray findings may be normal in patients with bronchiectasis. Chest X-ray in advanced cases may show 1 to 2 centimeter of cysts. They may show peribronchial thickening. They may show crowding of bronchi or ring opacity. So we can see cysts, we can see peribronchial thickening, we can see crowding of the bronchi or ring opacities. The main value of a chest x-ray is to exclude other causes of symptoms, and HRCT findings will include so we studied about x-ray findings, which can be uh, finding of cysts, 1 to 2 centimeters of cysts, peribronchial thickening, crowding of the bronchi or ring opacities, and it helps in excluding the other causes. HRCT findings would be bronchial dilatation, lack of normal tapering of bronchi, and bronchial wall thickening. So HRCT findings would be bronchial wall thickening, bronchial dilatation, and lack of normal tapering of bronchi peripherally. So we have to pay special attention to the findings of chest x-rays and HRCT, as these are commonly seen in the exam as well. Now coming to treatment part, a damaged lung cannot be repaired, so the basis of management is to prevent or at least slow down further deterioration in the case. So bronchodilators are the part of management. Bronchodilators. Second, chest physical therapy, postural drainage, which are used to improve the drainage of bronchial secretions. Then stop smoking, immunization against influenza and pneumococcus, long-term oral antibiotics for patients having 3 or more exacerbations per year requiring antibiotic therapy, or patients with fewer exacerbations that are causing significant morbidity. So bronchodilators, chest physical therapy and postural drainage, avoiding smoking, immunization against pneumococcus and influenza, then long-term oral antibiotics for patients having 3 or more exacerbations per year which are requiring antibiotic therapy, or patients with fewer exacerbation which are causing significant morbidity. Let's go through the chart once. So here we can see bronchiectasis is irreversible dilatation of small and medium sized bronchi. Along with that, there is chronic inflammation of the airways. Features: there is chronic persistent cough, copious sputum production, then recurrent respiratory tract infections, then clubbing of the fingers, that is a new thing, drumstick shaped fingers. So finger clubbing would also be there, drumstick shaped fingers, not always present, not specific. Chest x-ray will show tram lines plus increased bronchovascular markings, or maybe completely normal as well. Here we can see in this case increased bronchovascular markings and tram lines. Then we can see cysts or ring opacities, bronchial wall thickening in the left lower lobe. In this picture we can see bronchial wall thickening in the left lower lobe. Okay, initial diagnosis is by chest x-ray, but for confirming the diagnosis, definitive diagnosis is by high resolution CT scan, HRCT. Now the connection between cystic fibrosis and bronchiectasis. Bronchiectasis is the permanent dilatation and thickening of airways. Amongst many conditions which can result in bronchiectasis, cystic fibrosis is one of them. Patients with cystic fibrosis have recurrent infections as a child, which results in chronic inflammation leading to airway dilatation and destruction. So the patients with cystic fibrosis, they have recurrent infections as a child, which results in chronic inflammation leading to airway dilatation and destruction. So cystic fibrosis can lead to bronchiectasis. Around 0.6 to 2.7% of adults with diagnosed bronchiectasis have cystic fibrosis. All people up to the age of 40 with bronchiectasis should be investigated for cystic fibrosis. So cystic fibrosis is an important cause for bronchiectasis, a congenital cause, and we have to exclude it out as well, because patients with cystic fibrosis have recurrent infections as a child which can cause chronic inflammation leading to airway destruction and dilatation. And we already studied about the features. One new thing which we studied is clubbing of the fingers, that is drumstick shaped fingers. And in chest x-ray we'll see tram lines plus increased bronchovascular markings, copious sputum, chronic persistent cough, recurrent respiratory tract infections, then cyst or ring opacities, irreversible dilatation of small and medium sized bronchi. Okay, that is about bronchiectasis. Okay, so now let's move ahead. Next, a 40-year-old woman presenting to the emergency department with a history of sudden shortness of breath, which started 2 days ago. She denies having any recent fever or cough. Her vitals were taken and her temperature is 37.7, pulse rate is 101, blood pressure 127/81, SpO2 89% on room air. On auscultation, breath sounds are normal. Hemoglobin is 140, white cell count 11, platelet count 330, D dimer is 1532. A PCR COVID 19 test was ordered and returned negative. Her chest x ray, there's a picture of chest x ray which has been given. So, the single most likely diagnosis is being asked in this case. Now, here we have to study and refer to different things. Pulmonary embolism should be a top differential in any woman who presents with sudden shortness of breath and hypoxia. Her elevated D dimer is another clue which tells that pulmonary embolism is the most likely diagnosis. Pyrexia can also occur with pulmonary embolism, so fever can be there. D dimer is a clue towards pulmonary embolism. Now, all the other options like COVID 19, spontaneous pneumothorax, and atypical pneumonia, panic attack, they can be reasonably excluded. There is no evidence of infection based on the absence of cough and fever. Her COVID test is already negative. A normal chest x ray rules out a pneumothorax and hypoxia. Does not, and also, yes, we also need to know that hypoxia does not occur during a panic attack. During a panic attack, there is no hypoxia. So this is not panic attack. Because of that, there is no pneumothorax. Normal chest X-ray is there. There is no COVID 19 because COVID 19 test was already negative. And there is no evidence of infection based on the absence of cough and fever. So atypical pneumonia is also not there. So pulmonary embolism is the top choice here, and it should be a top differential in any woman presenting with sudden shortness of breath and hypoxia. Sudden shortness of breath and hypoxia, pulmonary embolism should always be on the top differentials. And elevated D dimer here is also pointing towards that. And in pulmonary embolism, fever can also be present. Okay, so let's study more about pulmonary embolism. Let's see if we have a chart on this. So, pulmonary embolism, first, the risk factors in order of importance. The risk factors in pulmonary embolism are surgery, second, pregnancy, including the postnatal period, third, lower limb injury, then malignancy, reduced mobility, and previous venous thromboembolism. So, risk factors are in order of importance. These are the risk factors of pulmonary embolism: surgery, pregnancy, lower limb injury, malignancy, reduced mobility, and previous venous thromboembolism. And if we see the signs and symptoms, we have to remember that these are non-specific, and the symptoms include dyspnea, pleuritic chest pain or retroesternal chest pain, cough, and hemoptysis. And the signs include tachypnea, tachycardia, hypoxia, which may cause anxiety, restlessness, agitation, impaired consciousness, then pyrexia, elevated jugular venous pressure, gallop heart rhythm, which is a widely split second heart sound. I mean, that's another sign other than gallop heart rhythm, and a tricuspid regurgitant murmur. Then we can have pleural rub, systemic hypotension, and cardiogenic shock. And all we need to remember in terms of diagnosis and management in context of this exam is that CTPA is the gold standard for the diagnosis of pulmonary embolism, and that immediate administration of therapeutic anticoagulation must be given once the pulmonary embolism is suspected, even before CTPA. Now, when we have to choose a chest x-ray over a CTPA, we choose chest x-ray in a suspected pulmonary embolism if the question is asking for initial investigation as opposed to most appropriate investigation. Most appropriate, we already know, is CTPA, that is CT pulmonary angiogram, but the most initial investigation can be chest x-ray in a suspected case. A chest x-ray is useful to rule out other causes of shortness of breath like pneumonia or pneumothorax, and if pneumothorax or pneumonia is detected, then that diagnosis is likely the cause of a shortness of breath, and the patient may not even need a CT pulmonary angiogram. Now, which therapeutic anticoagulants to use? If the patient is hemodynamically stable, then we use apixaban or rivaroxaban. Apixaban or rivaroxaban, these are the first line anticoagulants which are used if the patient is hemodynamically stable. If it is not suitable to use, then we can use low molecular weight heparin for at least 5 days, followed by dabigatran or edoxaban, or we can use low molecular weight heparin with a vitamin K antagonist like warfarin. But if the patient is hemodynamically unstable, then we have to start continuous unfractioned heparin, and we have to consider thrombolysis. So it is a very important point to remember that treatment dose of anticoagulants, and we need not focus too much on the prophylactic dose. So we need to use the treatment dose of anticoagulation, not the prophylactic dose, and treatment doses are much higher, are often higher than prophylactic dose. So before March 2020, according to NICE guidelines, doctors were using low molecular weight heparin treatment dose as the first line for suspected pulmonary embolism. However, now the guidelines have made it clear that we should be offering apixaban or rivaroxaban as the first line now in hemodynamically stable patients, not low molecular weight heparin for 5 days, followed by dabigatran or edoxaban, or low molecular weight heparin with vitamin K antagonist like warfarin. Okay, so again, talking about the risk factors first for pulmonary embolism. The risk factors can be surgery, lower limb injury, pregnancy, malignancy, reduced mobility, and previous venous thromboembolism. So, surgery, lower limb injury, pregnancy, mobility, immobility, long term immobility or reduced mobility, then malignancy, and previous venous thromboembolism. These are the risk factors for pulmonary embolism. Now, coming to signs and symptoms. Symptoms are dyspnea, pleuritic chest pain or retrosternal chest pain, and cough and hemoptysis. So these are very non-specific type of respiratory symptoms, which are dyspnea, then pleuritic chest pain or retrosternal chest pain, cough and hemoptysis. Signs include tachypnea, tachycardia, hypoxia, which may even lead to anxiety, restlessness, agitation, and impaired consciousness. Then pyrexia or fever can be there, elevated JVP, gallop heart rhythm, and widely split second heart sound, tricuspid regurgitant murmur, then pleural rub, systemic hypotension, and cardiogenic shock. So again, signs are tachypnea, tachycardia, then hypoxia, which is leading to anxiety, restlessness, agitation, impaired consciousness, and fever, elevated JVP, gallop heart rhythm, widely split second heart sound, tricuspid regurgitant murmur, pleural rub, systemic hypotension, and cardiogenic shock. Yes, systemic hypotension and cardiogenic shock as well. So yes, signs and symptoms are important here. Symptoms we can remember very non-specific: cough, hemoptysis, dyspnea, and pleuritic chest pain, retrosternal chest pain. Signs can be like tachypnea, tachycardia, hypoxia, which can lead to further agitation, restlessness, anxiety, impaired consciousness, fever. Then we can have systemic hypotension, cardiogenic shock, elevated JVP, gallop heart rhythm, and split second heart sound, tricuspid regurgitant murmur, pleural rub, fever or pyrexia. So these are the things. These are the signs and symptoms of pulmonary embolism. Now, in terms of diagnosis and management, CTPA, that is CT pulmonary angiogram, it is the gold standard for the diagnosis of pulmonary embolism. That is the most definitive diagnosis and gold standard. CTPA or CT pulmonary angiogram. And immediate administration of therapeutic anticoagulants must be given once pulmonary embolism is suspected, even before carrying out CTPA, even before carrying out CT pulmonary angiogram. If we are suspecting pulmonary embolism in a patient, we have to give a therapeutic dose of anticoagulants, immediate administration of therapeutic anticoagulation. That is very important, even before conducting a CT pulmonary angiogram. Now, when we choose chest X-ray over CTPA, we already studied that chest X-ray in a suspected pulmonary embolism is when they are asking for initial investigation, not the most appropriate investigation. Chest X-ray is useful to rule out other causes of shortness of breath like pneumonia and pneumothorax. But if chest x-ray is positive for pneumonia or pneumothorax, then the diagnosis is likely the cause of shortness of breath, and the patient may not even need CT pulmonary angiogram. Coming to the treatment, or coming to the therapeutic anticoagulation which is to be used, if the patient is hemodynamically stable, we will use apixaban or rivaroxaban. Now, if these are not suitable to be used, then we will use low molecular weight heparin for 5 days, at least 5 days, followed by dabigatran or edoxaban, or we will use low molecular weight heparin with a vitamin K antagonist like warfarin. So yes, this is about hemodynamically stable. In hemodynamically unstable patient, we will start continuous unfractioned heparin. Continuous unfractioned heparin in hemodynamically unstable patient. Continuous unfractioned heparin, and we have to consider thrombolysis. So two parts in therapeutic anticoagulation in pulmonary embolism. First is in hemodynamically stable patients, use apixaban or rivaroxaban, and if it is not suitable, then we use low molecular weight heparin for at least 5 days, followed by dabigatran or edoxaban, or low molecular weight heparin with warfarin, that is a vitamin K antagonist, warfarin. But if the patient is hemodynamically unstable, then we'll use unfractioned heparin, UFH, and we will also consider thrombolysis. Unfractioned heparin and thrombolysis. A very important point is to use a treatment dose of anticoagulation, not the prophylactic one. Treatment doses are often higher. Earlier, the doctors were using low molecular weight treatment as the first line, but now the first line is very clear, even according to the NICE guidelines, that we should be offering apixaban or rivaroxaban as the first line management. So now this is about pulmonary embolism. Let's go through the chart given here. Now, hints and features. First, there is history of prolonged immobility, that is after surgery, long haul flight. Then other risk factors are combined oral contraceptive pills, surgery, obesity, pregnancy, malignancy, previous venous thromboembolism, and one or more features may be present like shortness of breath, dyspnea, chest pain, often pleuritic, retrosternal, cough, hemoptysis, tachycardia, tachypnea. These are the features. Then investigation, most initial is chest x-ray, most appropriate is CT pulmonary angiogram or CT pulmonary angiography. Now, why is chest x-ray done first? It is to rule out other causes of shortness of breath like pneumonia or pneumothorax. If pneumonia and pneumothorax are detected, then the diagnosis are likely the cause of shortness of breath, and the patient will not need CT pulmonary angiogram. If if pulmonary embolism is being suspected, we have to treat it. We have to treat the patient. Immediate administration of anticoagulation should be there while waiting for carrying out CT pulmonary angiogram. So even before that, first line is by apixaban or rivaroxaban, and if not suitable, or second line would be low molecular weight heparin for at least 5 days, followed by dabigatran or edoxaban, or low molecular weight heparin followed along with warfarin, that is a vitamin K antagonist. If patient is hemodynamically unstable, then we'll use unfractioned heparin and thrombolysis. Now, a big brain trainer here. A man develops sudden chest pain and difficulty in breathing. He was treated for left leg cellulitis 7 days ago with flucloxacillin. His left leg is swollen and he has been immobile. His vital signs are within normal limits except for heart rate of 112, normal full blood count, and renal profile. Renal profile. What is the most initial investigation? Chest X-ray. What is the most appropriate investigation? CT pulmonary angiogram. We have to see here that the patient has been immobile. His left leg is swollen. And the patient is having symptoms like sudden chest pain, difficulty in breathing, and there is tachycardia as well. So all these are pointing towards pulmonary embolism, and in that case, obviously, initial investigation would be chest X-ray, and definitive or most appropriate would be CT pulmonary angiogram. Another one, a woman 2 days after hip replacement surgery presents with suspicion of pulmonary embolism. She states that she has been taking low molecular weight heparin as prescribed. What is the most appropriate action? Prescribe a higher dose of low molecular weight heparin and arrange a CT pulmonary angiogram. Okay, so this is another scenario here, and in this scenario, based on the situation of the patient, we can see that this is a post-surgery patient. So another risk factor for pulmonary embolism. Patient has already been taking low molecular weight heparin. So now what can we do? So we can prescribe a higher dose. Yes, we can prescribe a higher dose of low molecular weight heparin, and we can arrange for CT pulmonary angiogram. So this is about pulmonary embolism. Now let's take a break here and I'll be back.